with Chapter 4 of 321 Coded, 6th edition. This is by Michelle Green, and she has a technical reviewer on this book. Jessica Rosati is an RN in Cape Girardeau, Missouri, and some of you know I'm also from the Missouri, the Kansas City area. I presently have lived in California, Southern California now for the past 30 years, raised my children here. 2 of them are still in California. So, one's in college in Nevada and one's in Missouri, I think. So this is an extra long class because we're going to go over and look at each chapter in the ICD-10-CM manual. So let me see, make sure you have the right manual for this class. This is the AMA version, ICD-10-CM, the complete official code book. Okay. Hopefully you were able to get that on smile.amazon.com to support Cat House on the Kings or whatever charity you would like. Now, you know you can use smile.amazon.com for anything, even if you also have a Prime membership. So hopefully you know how to do that. Okay. So, ICD-10, long awaited. I literally had a class in Las Vegas of almost 25 RNs getting ready to do their test prep with me that week. On the day, it was announced that the Senate had managed to vote, and I don't think even most of them knew they had voted, that ICD-10 was not going to start in 14, it was going to start in 15. And the nurses turned around and looked at me and she goes, well, now what do we do? I'm like, get back in class, we still have work to do, you need to get your certification. Because what I was hearing from other nurses who had already been through the program was that they were using the certified RN coders who had been through my ICD-10 class as trainers in their hospitals. They said, there's work to do, just let's go. That was amazing. It's just totally amazing. Okay. You know, it's a shame they politicized the whole thing. But of course, that's the U.S. They did. And we finally did it. So we have been at ICD-10-CM now since October 1st, 2015. There are issues now with just, unfortunately, like we thought there would be, the non-clinical high school grad folks, the clerks, were supposed to be, over the last few years, they were supposed to be trained in A&P, medical terminology more, pathophysiology, pharmacology. Who does that sound like to you? Nurses? Okay. So what happens when a facility or a medical group does not file correct ICD-10s with their procedure codes, then you can't match up the data. You can't say, okay, so for myocardial infarction, we will accept these 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 ICD-10 codes, and that's it. So you can't get accurate data. It's a pure garbage in, garbage out situation. It really is. And it will affect reimbursement today, and it will really mess up fee profiles for the future and case mix. So you've got to have nurses in this game. You've got to have RN coders here. So let's go. ICD-10. So now I am in your 321 coded textbook, and I just sit there and messed it up again. I'm always folding it in different directions. 321 coded, and I'm on page 99, if you're with me. You may want to be following with your, ebook. And remember, we're going to be doing exercises, little exercises, starting with 4.1 on page 101. We're going to be doing those throughout the webcast. So you can pause me. I can't pause me, but you can. And you can do those. And remember, when you do them online, you're doing them for credit. So that's part of the program. So the rules developed by the cooperating parties for ICD-10 to accompany and complement official conventions and instructions provided within ICD-10-CM. And our information in this particular chapter is a companion to ICD-10-CM. The cooperating parties include the American Hospital Association, the American Health Information Management Association, AHIMA, Centers for Medicare and Medicaid Services, which is CMS, National Center for Health Statistics, NCHS. So these groups, as well as 3M, were involved in the development of the U.S. version of ICD-10, including CM, which is clinical modification. So it's a little different, as usual. The Yankees have got to be a little different. The Yanks, the Americans, as they call us in Belize, the gringos. Everybody's a gringo. Doesn't matter because you're from the U.S. Or North America. So know that this was a hard-won process. So the organization of the guidelines include, now your guidelines, let me show you where they are in your big book, front of the book. There's the history. We don't really need to do that. How to use. Now the how to use is a good, really good, well organized how to use the code book. So I expect you to go over that on your own. So overview of the ICD-10-CM official conventions. I'll start on VIII. We've gone through that a little bit in the intro. And then you have additional annotations on X. Okay, so organization of the guidelines includes Section 1, which is the structure and conventions. So I'm actually on page 1 of your ICD-10 CM manual, coding manual, okay? Official ICD-10 CM official guidelines for coding and reporting 2016. So it tells you that the 2017 were not available at the time the book was published. Please refer to page VI in front of the book for information on where to find the updated guidelines, if any. Okay, so Section 1 is the structure, conventions, and chapter-specific guidelines. Section 2 is guidelines for selection of the principal diagnosis for non-outpatient settings, which makes it inpatient. Section 3 is guidelines for reporting additional diagnoses in non-outpatient settings. Section 4 is guidelines for outpatient diagnosis coding and reporting. Appendix 1 is present on admission POA reporting guidelines. And in your text, we have, there is a note here. I'm sorry, on top of page 99. It says, when reviewing examples and completing exercises and review questions in this chapter, use your ICD-10 coding manual to locate disease and injury index entries and to verify them in the tabular list. So you've been officially told that you have to use your coding manual in this particular chapter. Okay, so if you turn the page with me, is there anything else I want to do? Oh, student companion website, don't forget. www.cengagebrain.com. You have additional content located there for this chapter. It says alternate healthcare facilities and coding guidelines and HIV-related conditions and opportunistic infections. So as, I try to cross-reference everything as we go, but it also cross-references in your text, which is really cool. So on page 100, it says that the structure and conventions of ICD-10 are discussed in chapter 3, and you should have already reviewed that chapter, and we're going to see the ICD-10 chapter-specific guidelines in this particular chapter, chapter 4. So I said we're going through every chapter, or every chapter in the book. Okay. So the important information here that you see is what we just looked at, what's in each section. And it does give you a HIPAA alert here on page 101, which is right here on the webcast slide, is It says the HIPAA regulations for electronic transactions require providers and third-party payers, including Medicare, administrative contractors, MACs, to adhere to the official guidelines for coding and reporting. And thus a violation of the coding guidelines is technically a HIPAA violation. That's called fraud. So everybody has to adhere to the same guidelines. So here's your first exercise in chapter 4-1. Now this is after you've had a chance to read through the guidelines on your own, as well as review the first 2 pages in this particular chapter. Instructions is just you have 10 complete each statement. Okay. Again, do it through your activity list or your ebook. Definitely through the activity list. I know they're listed there, and that's for credit. That's how I know you're working on your stuff. Okay, so General ICD-10 Diagnosis Coding Guidelines is giving you this information here. Locating a code in ICD-10 is we're going to be using both the index and the tabular list. We're going to locate each term first, like we've done in Chapter 3. We're going to locate it in the alphabetic index, and we're trying to get as much information as we can out of the alphabetic index so that we can get to the right part, the right place in the tabular list. So the codes range from A00.00 through T88.9, and then we have the Z000 through Z99.8. So the important thing to know is that, yes, you can code signs and symptoms in this book, in this coding manual. Yes, you can. And that the only reason you would be coding signs and symptoms is if you don't have a more definitive diagnosis. So maybe as the patient's visit progresses in the inpatient setting, you can continue to code signs and symptoms until you have a definitive diagnosis, if you actually get to one. Okay. However, you cannot report signs and symptoms in case you want to get paid. So on the discharge diagnosis summary for inpatient example, you have to have a real diagnosis there. Can't be signs and symptoms. The other thing on outpatient physician services, you're on a 24-hour clock, right? You're on a 24-hour clock, so you can only report a definitive diagnosis for that visit or encounter. Reporting signs and symptoms will definitely not get you paid, get your provider paid. So you can report conditions that are an integral part of a disease process, conditions that are not an integral part of a disease process, and then we're going to go over multiple coding for a single condition. We can code acute and chronic conditions. We can code a combination code. Those exist in here more than it did before. Sequela or late effects. We can code an impending or a threatening condition, and we can report the same diagnosis code more than once. So over here on page 103 of your 321 Code It, it says locating code in ICD-10. We're going to use both the index and the tabular list. And it says before assigning codes, review explanation and examples of ICD-10 coding conventions in Chapter 3. So you've already done Chapter 3. Okay. So first we're going to locate each term in the alphabetic index and verify the codes selected in the tabular list. You absolutely may not code from the index. That's a big no-no. It's been a big no-no for 30 years. It continues to be a very big no-no because the index doesn't have everything in it. The goal of the index is to get you to the right section of the tabular list, which is more complete, which is totally complete. Okay. So it tells you here in this other note that you have to use them both because the index does not always provide the complete code, what I just said. And then level of detail in coding. Pay attention to the level of detail when assigning codes because diagnosis codes are to be reported using the highest number of digits or characters available. Okay, so what that means is, let's say the Medicare claim system or the Blue Cross Blue Shield's claim system knows that a particular code is supposed to be 6 digits, and you only submit 4 or 5 digits for that code. So that means it's not as detailed, as specific as it should be, and that means that that claim will probably be rejected, if not outright denied. So rejection means that you can fix it and resubmit it with no issue. Appealing, you have to appeal denials. You don't really want to go there. We cover that in RN Auditor. That's extensively different than what we're doing today. So level of detail is very important. That is why nurses, I believe, are so good at this, because your level of detail is so much higher because of your experience in reading charts and providing care to patients, working with physicians. The whole thing makes you so much better at this. So we go from A00.0 to T88.9 and then the Z codes. We can actually code laterality. Can you believe that? That for the last 30 years we have not been able to code right and left? What is more important on the body than right and left? But ICD-9 did not have it. Never did. We coded right and left with our procedure codes on the physician side. Some of you know that I'm a healthcare administrator, but I'm really a medical administrator on the medical group side. So we could code RT-LT as a modifier on our CPT codes or our HCPCS codes. But that's the only way we could do it. So we can actually document body mass index, BMI, and pressure ulcer stages now. We can code syndromes better, and we have documentation of complications of care is far better in ICD-10, much more specific, which makes it more trackable and comparable. So I am over here on page 104 in your book, but I'm not quite there yet with this. So the important part to understand with this in your guidelines is to clarify assignment of disease codes. Unless otherwise indicated, chapter-specific guidelines apply to all healthcare settings. And here's some guidelines for the following terms. So principal diagnosis is reported for inpatient care. The definition is that condition established after study to be chiefly responsible for requiring the admission of the patient to hospital for care. That's the inpatient principal diagnosis definition. We have secondary diagnoses, additional conditions that affect the patient care today for requiring clinical evaluation, treatment, diagnostic procedures, extended length of stay, increasing nursing care, and monitoring. So secondary diagnoses are very important to document in the chart so they can be coded if they affect today's treatment of the primary situation. So let me give you an example that I've used for years that I know nurses get. So you're in the ER and you're taking assignment of a patient older lady who was in a car accident. Her son was driving. She has actually a fractured femur, and because she was hit on that side of the car. And you're getting a history, and she says, well, I have diabetes, and I'm not feeling really good right now because I've missed my insulin dose. What do you do? Now you're treating two conditions, right? You must document the diabetes. You have to get the information so you can get her insulin. Maybe in the car, it might have been towed. Who knows where it is? But you should be able to get that information so you can medicate her. But what if she tells you instead of diabetes that she's a 5-year breast cancer survivor, and is that important? Is that going to affect today's treatment of the acute of the fractured femur? No, it's not, because the car accident caused the fracture. Okay, not any bone metastases or anything like that, and you can't pick that up on X-ray anyway. Okay, so So know that secondary diagnoses are extremely important to be documented, especially if they have to be treated or they somehow affect the treatment of the acute today. Okay? First listed diagnosis. A first listed diagnosis, I'm trying to figure out what page in the book we're on. I don't see it yet. So the first listed diagnosis reported for outpatient and physician care. First listed is the diagnosis, condition, problem, or other reason for the encounter or visit documented in the medical record to be chiefly responsible for the services provided today. So first listed is for outpatient and physician care. Okay? It's what we're treating today. If this encounter, you're on a 24-hour clock on those, right? So depending on the severity of the patient, is either going to be discharged or admitted, right? Maybe transferred. Okay. So we have, this is not always matching up. But remember, this is a brand new edition of the book, brand new PowerPoints, and they all came from the publisher, and sometimes they match up and sometimes they don't. So here we go. We have codes are A00 through B99. In this section, classifies communicable diseases, diseases of unknown origin, organisms, bacteria, chlamydia, fungi, the myco, and the mycoplasmas and the viruses. So let's see. We should be on. We still aren't. I'll figure this out. We'll see. Stay with me. We can code HIV. HIV positive individuals unable to ward off microorganisms. We understand that. We can locate phrases in the patient record to determine whether the patient is considered HIV positive, as you know. So that was chapter 1. Hang on a second. Chapter 1. So let's see where it starts. Aha. So in your book, we were at, remember we were at that first exercise. So over on page 104, it talks about signs and symptoms. We already discussed why we're not going to use those for a reimbursement or on an insurance claim. Now, let's discuss conditions that are integral to a part of a disease process. That was back here, wasn't it? So I did have it. Aha, there it is. Okay. So on page 104, you have conditions that are an integral part of a disease process. Signs and symptoms that are associated with the disease process should not be assigned as additional codes unless otherwise instructed by ICD-10, because they're included. That's what I'm saying. They're included. And so it gives you an example here. We're not going to look it up right yet. Assign ICD-10 CM J18.9 to the pneumonia. Oh, I'm sorry, I missed the example. So the patient is seen at the hospital's emergency department with a complaint of shortness of breath. That's all they know, shortness of breath. Chest x-ray reveals pneumonia. That's figure 4.3 over there. And the ED physician prescribes an antibiotic. Okay. So we're going to identify this as pneumonia, J18.9. Remember, I've already shown you that code. That's why we're not looking it up right now, because I've already shown it to you in chapter 3. Do not assign a code for the shortness of breath because it's a symptom of the pneumonia. Okay? Why is this not a good code for pneumonia? Because we need to know what caused it, right? We need the cause. We need at least bacteria versus viral. We need at least that much. Conditions that are not an integral part of a disease process. So here on page 105 is the discussion for that. Conditions that are not considered an integral part of the disease process, such as additional signs and symptoms that may not be associated routinely with the disease process, should be coded when present like a severe headache for which treatment and medical management is provided when the patient is diagnosed with pneumonia. So it gives you another example here. So how to determine which is which of what you're reporting is really important. So this patient was identified having hypertension. And so you would report the pneumonia as the primary or principal diagnosis, and then hypertension as a secondary diagnosis. Now, multiple coding for a single condition is interesting. It gives you a note here at the bottom of page 105. Are you with me in 321 code it? Multiple codes may also need to be reported for ICD-10 sequela, complications, and obstetrical cases to describe more fully the patient's condition. So you refer to that specific guideline, and that's why we're using the term sequela more than late effect. So multiple coding for a single condition is an etiology or manifestation. Coding convention requires that two codes be reported to completely describe a single condition that affects multiple body systems. Okay, so it gives you an example here we are going to go over is diagnosis is the amyloid neuritis requires ICD-10-CM E85 and G63 be reported. So let's look that up first before we go further. So grab your big, huge book, and you're looking up. What are we looking at? We're looking at neuritis, right? Neuritis. So let's see if that works. Looking at neuritis, N-E-U. I'm actually spelling to myself. N-E-U-R-I-T. Yeah, neuritis, there it is. Okay, so neuritis is over here on page 230. Page 230. Let's see if I can pull this over onto my laptop and it won't crash. It didn't. Okay. So neuritis, down here at the bottom of page 230, and then we're looking at the amyloid. So then you see on the second, at the top of the second column, we're on page 230, amyloid, neuritis amyloid, any site, E85.4, and you see the G63 there in brackets. Do you see that? Just highlight it real quick or underline it, just so you know you've been there. So let's go back then with the E85.4. I'm going to always write these things down so I don't lose them. E85.4. So we're going to take it and look it up in the tabular list. And you will find yourself in the pretty yellow section, Chapter 4, Endocrine, Nutritional, and Metabolic Diseases, E85.4. It's almost at the back. So I'm on page, tiny in print, 515, E85.4. I'm not on that page, I'm sorry. There it is. We're on page 514, not 515. So E85 is the amyloidosis. It tells you that it excludes Alzheimer's disease. There's an exclusion. And then we're looking at 85.4, organ-limited amyloidosis, localized. Okay. Now, right now, it doesn't say anything about that G diagnosis, does it? So you're still required to report it because it's included in the index. So even if you don't see it in the tabular list, it's in the index related to E85.4. So what you do is you go back to the chart and say, where is this other part? And do I have to report it? You have to report it if it's documented. Okay? So we went through that, and we're on page 106. Acute and chronic conditions. Did I already pass that? I mean, I know I did. There we go. Acute and chronic conditions. If the same condition is described as both acute and chronic, or subacute, and chronic, and separate subentries exist in the ICD-10 index at the same indentation level. Same indentation level, code both and the sequela of the acute or subacute code first. Okay, so here's an example. The diagnosis of acute gastritis and chronic gastritis are assigned ICD-10 codes K29.00 and K29.50 in that order. So let's just look that up in the tabular list. So again, write it down. So we're looking for the K29.00.00 and the K29.50. Okay. So we need to figure out what's acute and what's chronic for the codes. So we're looking at we're in the purple section. It's so pretty. Chapter 11, diseases of the digestive system. K29. So that should be over here on page 663 of your tabular list. K29. K29 is gastritis and duodenitis. Sorry. Tells you what's excluded here. So we're looking for K29.00. Do you see how that's indented there? Acute gastritis without bleeding. So you have to make sure in the chart that it doesn't say anything about bleeding. Otherwise, you have to use K29.01, acute gastritis with bleeding. See how that's color-coded there in the green, so it helps you see it? So that gives you the instruction to go back to the chart and say, do we have bleeding reported or anything? So then you go down to, we're assuming it's without bleeding, so it's K29.00. Then we're looking at K29.50, and that's in the next column up the top. K29.5 is unspecified chronic gastritis, but it says K29.50 unspecified chronic gastritis without bleeding. So see how it matches? Okay. So we're going to be reporting both of those codes, and we're always going to report acute as primary or principal. Acute always trumps chronic. We're going to have to get a better term for that. So acute and chronic. Chronic comes first always, because that's what you're treating today. So you have a combination code here where it discusses that on page 106 when you do your reading. Assign a combination code when available and multiple codes as needed. It says a combination code is a single code that is used to classify two diagnoses, a diagnosis with an associated secondary process like a manifestation, or a diagnosis with an associated complication. So combination codes are located by referring to a subterm entry in the ICD-10 index and followed by includes or excludes notes in the ICD-10 tabular list. So assign two or more multiple codes to completely classify the elements of a complex diagnosis. So it gives you an example down here of a combination code. Let's look at it. Example 1. Assign ICD-10 combination code K80.00 to the diagnosis of acute cholecystitis and cholelithiasis because the code description includes both conditions. So the fifth character 0 is assigned to this code because there is no mention of obstruction. So let's look that up. That's real interesting. So we're already in the K section. That's why we're going to look it up. So it is, right? It is K80.00. We were in K29, so it should be close. Should be towards the back of the section. So K80. We need K80.00. So we're on page 673 of your coding manual. See that? So K80 is cholelithiasis. K80.00 is a calculus of the gallbladder with acute cholecystitis without obstruction. So with obstruction would be 01. So you see how important that last digit is? It's very definitive. You either have a calculus or you don't. You either have a stone or no. So that is why you can't miss these numbers, these last digits. That is why you can't code from the index, because sometimes they're not there. So it shows you that you have other information that's coded with K80.00. Sequela, late effect. And do we have that? Yeah, there we go. I moved it. Sequela is a residual effect, condition produced after the acute phase of an illness or injury has terminated. There is no time limit. That's very, very important. You should highlight that in your book. Put a post-it note on it or something to call your attention to it later. You may need it. There is no time limit on when a sequela code can be used. The residual may be apparent early, like hemoperisis in a cerebral infarction, or it may occur months or years later, like scarring due to a previous burn. I mean, there's a variety of situations here, but there is no time limit on sequela. So coding of a sequela, I'm at the top of page 107. Coding of a sequela generally requires two codes, sequenced in the following order. Okay, so this is how you do sequela. Residual condition or nature of the sequela is sequenced first, and sequela code is then sequenced second. So there's an exception to the above guideline, of course. In those instances where the code for the sequela is followed by a manifestation code identified in the ICD-10 tabular list, or the sequela code has been expanded at the 4th, 5th, or 6th character level to include the manifestation. So that is one of the best things that we know about ICD-10. We have codes now all the way over to 6 character to identify all the manifestations that we could possibly need. The code for the acute phase of an illness or injury that led to the sequela is never used with a code for the late effect. Why would that be? Because we're not treating the acute phase. We're no longer treating the acute phase today. We're going to be treating the sequela, probably, the late effect today. That's why the patient presented for care. So in your index, ICD-10 index is the main term sequela. Let's look that up. I want you to see it so you know where to find it. Put a post-it note on it. So in the alphabetic index, I want you to find the term sequela. It's a big section. It starts on page 283 of your index. You see that? Sequela, it's in the lower first column. And it says sequela of, or see also condition. Okay? So the sequela tells you this section, you have to know what your acute phase was. You're not coding it, but you have to know what it was in order to find the sequela in this section. Because you see then the sequela goes through to page 284, and it's in alphabetical order under sequela of the acute. Okay. So remember, in the late effect or sequela area of the book, the acute phase has ended. So that is why we're not coding it. Okay. You do not confuse your sequela with complications. I don't think you would. That are associated with a current acute illness. Multiple codes are assigned to classify sequela when no combination code exists, such as headache due to intracranial injury without loss of consciousness that occurred several years ago. So ICD-10 you would code the G44.90 and the S06.9XOS. You have the X there. It's a placeholder. Are both assigned. So in ICD-10-CM, the sequela of injuries are classified by assigning an S as the seventh character of the injury code. Now you're going to have some of those to work on in your workbook as well as in your exercises. So make sure you don't miss them. They're quite fun. And then gives you an example here on page 107. We're still on page 107. Patient was in an automobile accident last year and sustained fractures of the left femur and right tibia, which healed without incident. The patient presents today for stiffness in the left hip and numbness in the left leg. So you would be assigning a code to the stiffness of the left hip, which is M25.652. We don't need to look those up right now. Numbness of the left leg, which is R20.0, which is a sign and symptom, numbness, and sequela of a fracture. So we're actually going to code the sequela at S72, but the fracture is the code. So let's look that up really quick. S72. I want to make sure you know the difference. So we're back in chapter 19 under injury. There's a bright green section. And we're looking at S72. It's also a big section. And it is S72. See, I didn't write it down. I'm very bad. S72. You need to at least underline it twice. S72.92. Let's start with that. S72.92 is going to be on page S72. 92. It's at the very, very bottom of 977, page 977. Do you see that? S72.92, unspecified fracture of the left femur. See that little tiny box there, a little tiny blue box? Isn't that cute? It says that's a placeholder alert. You see that? Placeholder alert. And the what do you call that? An upside down triangle. See the upside down triangle, the blue at the bottom? That actually says it's an unspecified diagnosis. But we're really not going to report it, right? It's just the fracture code. So we're not going to report it because today we're treating the stiffness of the hip and the other injury, the sequela of the other injury. Okay, so we're going to assign the sequela for the injuries classified as assigning S. So we're not going to assign that S code. I'm just showing you where it is and what it looks like. So we coded the stiffness of the left hip is the M25.652. The numbness in the left leg is the R code. Okay. Impending or threatening condition. Where is that? We're going to go back. So I'm still on page 107 of your 321 code it. Impending or threatening condition. Coding an impending or threatening condition applies to inpatient cases only. Okay, that's very important. Inpatient only. I would write that in your book if I were you. I know the note is there, so it's up to you. I love to write in my book. Got me in more trouble until I got to college, and then they were my books, and I could write them if I wanted to. So code any condition described at the time of the encounter or visit as impending or threatened as follows. So here are your guidelines for impending, or threatening condition. If the condition did not occur, if the condition did occur, code as confirmed diagnosis. Okay? If the condition did occur. If the condition did not occur, reference the disease index to determine if the condition has a sub-entry for impending or threatened, and also reference main term entries for impending or threatened if it has not occurred. If a subterm for impending or threatened is listed, assign that listed code. If subterms for impending and threatened are not listed, code the existing underlying condition and not the condition described as impending. Okay? Has not occurred. So here we go. Interesting example. The patient is treated for an impending MI and is assigned ICD-10-CM code I20.0 because the MI diagnosis has not been confirmed. How do we confirm that? Namely EKG and what else? You have some lab tests and things to do. Okay. I'll post a note covering my book here. Page 108 example. Okay. So we also have reporting the same diagnosis code more than once. Each unique ICD-10 diagnosis code is reported only once for an encounter, once per encounter. This applies to bilateral conditions when there are no distinct ICD-10 codes identifying laterality, or two different conditions that are classified to the same ICD-10 diagnosis code. So even if I don't do I had a sleeping cat in here and now it's not sleeping. I'm sorry. We'll get over it in a minute. Hairballs. So on March 14th, the patient was diagnosed with bilateral lung abscesses. Even though both lungs contain abscesses, assign ICD-10 code J85.2 only once. So let's just look at that in the tabular list. J85.2. I think he's okay. I don't think you can see him. Let me see if I can. There he is. This is my pretty storm cat. He's beautiful. I know he looks like he's a blue point scientist, but I knew his mother and brothers. Okay, so we're going to J85.2. Did you get it? I think you did. Okay, J85.2. Let's go to HI2. So there's H, I. J is the yellow section, Joyce, not the red. It's usually respiratory. Here we go. Are you okay? All done? My goodness. Okay. Sorry about that. I'm going to have to put it out. Okay. So J85.2. Yellow section, chapter 10. Hang on a second. Let me get this cat. Come on. Gotta go. No, you can't have my microphone. Nothing. Everybody okay? Nope. Can't come back. No, you stay out. Okay. Sorry. Usually you do not have to put cats out. Didn't even know he was here. Okay, so J, 85.2 is, you've probably already found it by now, and I haven't. I have it on top of page 653 in your IC-10 manual. So J85 is an abscess of lung and mediastinum. Use additional code to identify an infectious agent. That's good information to know. So we were looking at 85.2, abscess of lung without pneumonia, absence of lung, NOS. Okay, so we don't really have to report both of those. Okay, don't have to report those. Just one. Okay, so we are at laterality, right and left. Oh my goodness. I can't tell you how much fun we've had with this. Oh my goodness, we have right and left. So it does give me an example of, first of all, codes that indicate laterality specifically classify conditions that occur on the right, left, or bilaterally. If it's a bilateral ICD-10 code, not provided, and the condition is bilateral, assign a separate code for both right and left side. If the site is not identified in the patient record, assign a code for unspecified. No. That is not correct. I want you to highlight that and say no. Joyce said no. Okay, I want you to go back, talk to the physician, or query the physician, or send an email to the physician. Was this right or left? Do not submit an unspecified code at this time with ICD-10. Don't do that. That will totally screw things up. You have to have right or left. Obviously, it has to be documented. Okay. So I always show you that because it's a big no-no. We're not going to report that. If you know that it's bilateral and you're a nurse, you're probably going to know some of that. And it doesn't say bilateral. You have to go back and you have to get it. Do not use unspecified. Okay, so like there's an example here. It's kind of interesting. It's bilateral contusion of fallopian tubes. Initial encounter assigned is code S37.522A. So in that code, if you look it up, we're not going to right now, but if you look it up, it'll say bilateral contusion of the fallopian tube. Okay. So let's go to documentation for body mass index. That's very new. I've never been able to do that before. And the assignment of body mass index, the depth of non-pressure chronic ulcers, pressure ulcer stage, coma scale, and NIH stroke scale may be based on documentation from clinicians who are not the patient's provider. Could be, other physicians along the way, or other providers. So basically, it's whoever is accountable legally for establishing the patient's diagnosis, because such information is typically documented by other clinicians involved in the care of the patient. However, associated diagnosis like overweight, obesity, acute stroke, pressure ulcer must be documented by the patient's provider. So if conflicting documentation is evident in the patient record, either from the same clinician or different clinicians, you have to you have to contact the patient's attending or primary care physician. So BMI, coma scale, National Institute for Health stroke scale codes are reported only as secondary diagnoses. Very important. All of this is secondary diagnosis. So you might want to highlight that or underline it. As with all other secondary diagnoses, BMI and pressure ulcer stage codes are assigned only when they meet the definition of a reportable additional diagnosis. So here's an example. It says the patient's BMI of 39.4 was documented by the dietitian. Very common. And patient has established diagnosis of morbid obesity. So you would report in this situation for this patient, ICD-10 CM codes E66.01 for what? The morbid obesity, and Z68.39 in that order. Now, let's look up that Z code. Z codes are interesting to me because we've never had them before. So, Brady Jones Royce, it is Z6839. Oops. What did I do? Okay, we're right there. Okay, so Z68.39. I love Z codes. Complete back of the book in the cherry red section. So Z68.39. Here we go. So I am on page 1159, 1159, bottom. It starts with body mass index, BMI, Z68. See, it's got a whole column here of stuff. So Z68.39, 68.3. Then we're going to go down all the way down to Z68.39, body mass index, 39.0 to 3, 39.9. See that? Adult. Okay. So I just wanted to show you the Z as an excuse to show you the Z codes. These are factors influencing health status and contact with the health services. So we had codes like this. We didn't call them Z codes at the time, but we always have to have a reason for the visit. So what if you have well baby care or pregnancy care or, developmental care with kids? They have to get their immunizations and stuff. And yes, I really support immunizations, but I like alternate schedules. Okay. I'm a midwife. I have to talk to parents about stuff like that. Okay, so these codes here, they're encounters for, like, for fitting and adjustment of an orthodontic device, Z46.4, or a Z code could be Z47, orthopedic aftercare, or encounter for attention of artificial openings, which is Z43. So these are reasons for encounters that you're following up with something. Encounter for genetic testing of male, it's very specific, of male for procreative management. So that is Z31.44. So Z codes are kind of cool, and they're always secondary. I'm sure there's a counter to that. But they are reported as a secondary additional diagnosis. So syndromes are interesting. Gives you a couple of sentences here about syndromes. I'm at the bottom of page 108. See why this is going to be a long class? So you guys can shut me off and start over. But I have to keep going. Okay. So follow the alphabetic index guidelines when coding syndromes. In the absence of index guidance, assign codes for the documented manifestations of a syndrome. Additional codes for manifestations that are not an integral part of the disease process may also be assigned when the condition does not have a unique code. So just like we saw in the sequela section of the index, when you look up the word, let's just do it real quick. It's never quick, is it? Syndrome is just the syndrome, the word syndrome, and it starts on page, it's a very, very thick section. Starts over here on page 297. Might want to just put a post-it note on it. Syndromes, it says see also disease. And again, the syndrome is in alphabetical order. So you start with the word syndrome, and then you find as much information here in the index. You take that code and go back to the tabular list. So documentation of complications of care are on the top of page 109. Complications of care codes are based on documentation of a relationship between a condition and the procedure unless otherwise instructed by ICD-10-CM. Not all conditions that occur during the following medical care or surgery are classified as complications. There must be a cause and effect relationship documented between the condition and the procedure of service provided, along with documentation that the condition is a complication. The physician has to document that it's a complication. There we go. If you're looking at a complication, and in your head it's really, this is like a complication of this, but you can't find it in the chart, you're going to have to query or email a physician. Sorry. Page 109, borderline diagnosis. So if the provider uses the term borderline or borderline diagnosis, borderline, hypertension, borderline diabetes, whatever, at the time of discharge, again, this is inpatient, code the diagnosis is confirmed unless ICD-10 provides a specific entry, like a borderline diabetes. That's actually an entry. If borderline condition has a specific index in ICD-10, it should be coded like that. Because borderline conditions are not necessarily uncertain diagnoses, no distinction is made between the care setting, so we don't care whether it's inpatient or outpatient or physician. Whenever the documentation is unclear regarding borderline condition, you obviously have to obtain clarification from the provider, from the physician. Okay. Does it go? Nope. Not yet. And then use of signs and symptoms and unspecified codes. Remember, that's a no-no. Just put no. And in the next year or two, it's going to be even more critical to make sure these codes, these unspecified codes, are not getting into the database. You may not use them, period, in outpatient physician claims, and they're not a good idea in inpatient. Okay, so here's exercise 4.2, general ICD-10 diagnosis coding guidelines, 1 through 15. Biggest exercise so far. So take a few minutes, probably 10 or 20, not sure. No one's done it yet. So at the time of this recording. So now we're going to go next into, hi, welcome back. We're going to go into chapter-specific diagnosis coding guidelines. So again, we have the principal diagnosis we talked about for inpatient care only. It's that condition after study to be chiefly responsible for having the patient admitted to the hospital for care. Again, we've already talked about a secondary diagnosis, which is additional condition that affects, I'm at the bottom of page 110, in case you're following along in your book as well. So secondary is reported for patient care in terms of requiring clinical evaluation, therapeutic treatment. So in other words, if we're going to treat it today, we probably want to report it. And then first listed is the new term for physician/outpatient care instead of principal. It's that diagnosis, condition, problem, or other reason for the encounter for today. And it has to be documented. So here on page 111 is a really cool, and let me see if it's in here. It's not, as far as I can tell. ICD-10 chapter-specific coding guidelines. So it's table 4-1. I'm on page 111. Locate the ICD-10 chapter-specific coding guidelines online. Go to www.cdc.gov. Click on the letter I think that's an I, maybe L, link. You have to get there. And go to, and click the ICD-10-CM link, scroll down, you'll see the guidelines, which will open into a Adobe PDF file. So just want to cross-reference that for you. So ICD-10 Chapter 1 is the certain infections, parasitic diseases, tuberculosis, other bacterial. We talked about the HIV information in here, so let's turn the page. So in your coding manual, grab it. So go back to the tabular list. Just love that pretty blue section. We're in Chapter 1, which is the green section. Starts on page 429. So there's Chapter 1 of the tabular list. This is what we're going to be going over now. And your book. We're not going to go into HIV specifically. Okay. Coding guidelines. Then start on page 114. Chapter 1. And it's in purple, kind of a purplish or gray. Maybe it's gray. Kind of a gray background. Do you see that? So that is going over the HIV virus. We're not going to actually go over that specifically, but you're expected to read it. You can take a few minutes to read it. But what's important I want to show you here is B, infectious agents. C, infections resistant to antibiotics. Sepsis, severe sepsis, and septic shock is D. Urosepsis, it talks about the term urosepsis is a non-specific term, and we don't consider it synonymous. That's the top of page 117. Do you see that? Not considered synonymous with sepsis, has no default code. So urosepsis is kind of a no-no. Okay, where's my pen? Kind of a no-no. We don't like urosepsis. It's a no-no. And physicians love it. It's their favorite go-to term. So it's a no-no. And then 3, it says sepsis with organ dysfunction. We sort of looked at that a few minutes ago. 4 is acute organ dysfunction that is not clearly associated with sepsis. And then B, definition of severe sepsis. So ICD-10, and this just keeps going down with sepsis. Sepsis and severe sepsis with localized infection, sepsis due to a postoperative procedure infection, all of this, we've gone through a lot of work on getting sepsis and septic shock and everything defined in ICD-10. We did not have this ability in ICD-9. More sepsis, 6, 7, and 8, newborn sepsis. E is methicillin resistant, Staphylococcus aureus, MRSA conditions. Okay. Zika, we have Zika infections on F. Code only confirmed cases of Zika. And that's A92.5, documented by the provider. This is an exception to hospital uncertain diagnosis inpatient guideline that in that context, confirmation does not require documentation of the type of test performed, just that it's been confirmed. That the physician's diagnostic statement that the condition is confirmed is sufficient. Okay. So in that section goes into sepsis. That is an important section. You might want to highlight it, or certainly make sure you know where it is for your, by putting a good old Post-it note, yellow. So exercise 4.3 is certain infectious diseases. This is chapter 1, and it says underline the main term in each diagnostic statement and assign the appropriate ICD-10-CM code. So you have just five, at the bottom of page 119. Okay. So turn the page. We're doing Chapter 2, Neoplasms. That's C00 through D49. Neoplasm is obviously a new growth or tumor in which cell reproduction is out of control. We have benign, which is non-cancerous. We have malignant, and we have epithelial, which is carcinomas, connective, sarcomas, leukemias, which is blood. So here on page 120, it tells you very specifically how we use the neoplasm table. So let's find the neoplasm table in your ICD-10 book. It used to be alphabetized with the N's. It's no longer that. It is now in this book on page 328 at the end of the alphabetic index. Okay, do you see that neoplasm table? So we looked at this briefly when we did our overview in chapter 3. We're going to look at it in a little more detail. But it tells you here we're going to, the note says that this, the list below gives the code number for neoplasms by anatomical site. And then you determine if it's malignant primary, in the chart it'll say malignant primary, secondary in situ, or benign. And the description of the neoplasm will often indicate which of the 6 columns is appropriate, like malignant melanoma of the skin. And then the tabular list must be reviewed for the complete code. A big important thing to do. So even as cool and as complete as this table looks, it's far more complete than it was. You still have to take that code that you've determined, and you go back to the tabular list. Okay. So obviously, primary malignancy is the original tumor site. And a note here that you might want to really highlight is that malignant tumors are considered primary unless otherwise documented as metastatic or secondary. Okay, so if it's not documented, it's primary. But if you're looking at something in the chart and it reminds you clinically that this might be metastatic or secondary, you're going to have to clarify that with the physician. Make sure it's documented. Secondary is metastatic. Tumor has metastasized or spread to a secondary site. Carcinoma in situ is malignant tumor, is localized, circumscribed, encapsulated, non-invasive, but has not spread to deeper tissues. Benign we know is non-invasive, non-spreading, non-malignant. Uncertain behavior is interesting because subsequent morphology or behavior that cannot be predicted based on the submitted specimen. So again, this is all coming off of specimens, pathology specimens, right? So it tells you to assign a code from the uncertain behavior column, the path report must specifically indicate uncertain. You're not making that up. The doctor's not making this up out of thin air. It's got to come from the path report. So then we go to page 122. Gives you some additional coding types. Coding information, assigning codes from neoplasm table is, again, we know, 2-step process. First, classify the neoplasm by its behavior, malignant or benign, and then classify neoplasm by its anatomical site, and then, of course, go to the tabular list. So it gives you a lot of more information here on page 123 about sequencing of neoplasm codes depends on the reason for the encounter. We're at the top of the page 123. Sequencing of neoplasm codes depends on the reason for the encounter. Review the record to determine whether the primary or secondary cancer site is being treated or medically managed. So again, what site, if you're dealing with multiple sites, what site is being treated today for this encounter? That's the key. So as you go forward in your reading with chapter 4 on page 124, it says, if the diagnostic statement does not specify whether the neoplasm is primary or secondary, code the site as primary. Again, I think I said that. Lung is not included in the list of secondary sites, therefore lung cancer is coded as primary, unless the physician says it's secondary. What if the anatomical site is not documented? First of all, I'm not sure how that happens, but if the cancer diagnosis does not contain documentation of the anatomical site, but the term metastatic is documented, assign codes for the unspecified site for both primary and secondary. What if the primary malignant site is no longer present? We've removed it. So if the primary site malignancy is no longer present and no further treatment is being directed at that site, do not assign the code for primary unspecified site. Instead, classify the previous primary site by assigning the appropriate code for category V10 personal history of. So we do have V codes that shows personal history of. We also have V codes for V10. We also have V codes for family history of. So watch that. We'll talk about those later. So it gives you some more coding tips here on page 125 that you should read through. Like read all notes in neoplasm table that apply to the condition you're coding. Never assign a code directly from the neoplasm index. You've got to go to tabular list. Morphology of neoplasm. The World Health Organization has published an adaptation of ICD-10 oncology that contains a coded nomenclature. So if you go to the student, tells you the student companion website is www.cengagebrain.com for the morphology of neoplasm codes document, and it shows you this information of how the morphology is. And go to page 126 here, how it's identified. So the general guidelines here starts on page 126 at the bottom. Chapter 2 contains the codes for most benign and malignant neoplasms. Certain benign neoplasms, such as prostatic adenoma, may be found in specific body system chapters. Primary malignant neoplasm, overlapping site boundaries. So that is right there. Yep. And just give you some really good basic information here on 126, 127, 128, 129, and 130. Okay? So we're not going to read all of this because I'm going to expect you to read it personally. So as you go through this, just make sure you're taking notes and everything. So you do have 5 little exercises here, 4.4 neoplasms. Underline the main term in each diagnosis statement and assign the appropriate ICD-10 code. So remember, you're looking it up in the index and you're verifying it in the tabular list, right? So let's just look at lymphoma, number 5, lymphoma, skin of abdomen. What are you going to look up? Lymphoma in your alphabetic index. Okay. Moving on to chapter 3, disease of the blood and blood-forming organs, certain disorders involving the immune mechanism. So these are D50 through D89, classify as nutritional anemias, hemolytic anemias, aplastic and other anemias, and other bone marrow failure syndromes. Starts here on page 131 of your 321 codec. And I have a star here in the on the book. It says bone marrow is the principal site for hematopoietic cell proliferation and differentiation. One of the largest organs in the human body, hematopoietic tissue is responsible for producing erythrocytes, red blood cells, neutrophils, eosinophils, basophils, monocytes, platelets, and lymphocytes. So this is going to be a large section in this book as well, in this chapter. It classifies coagulation defects, hemorrhagic conditions, other disorders of the blood and blood-forming organs, intraoperative post-procedural complications of the spleen, and certain disorders involving the immune mechanism. So as you read through this chapter of ICD-10, chapter 3, you're going to see some examples of, like here at the bottom, blood protein factor 2, prothrombin, is activated by the enzyme thrombin, is designated as factor 11A. Just side information here. So here, what's interesting here on page 132, we have the first one of these, chapter 3, diseases of the blood, blood-forming organs, reserved for future guideline expansion. So that's what we've got here. We don't have a lot of information here. So exercise 4.5, you have 5 there, disease of blood, blood-forming organs. So you're going to look up these 5 conditions and add the, so make sure you're doing this in your activity list. Make sure you're doing it for credit, okay? Chapter 4 is endocrine, nutritional, metabolic diseases. Again, let me show you over here in your really pretty color, yellow. So pretty in yellow. It's nice that they did the red in diseases of the blood and blood-forming organs. I thought that was cute. Okay, chapter 4, endocrine, nutritional, metabolic diseases, starts on page 497 of your tabular list. Starts with diabetes mellitus. Chapter-specific guidelines for this have been provided below. Along with these guidelines are coding examples contained in the shaded boxes. So it's really kind of cool about this. First page here, first page and 2. Diabetes mellitus has an amazingly updated, very well documented, and very specific section now. And gives you guidelines of assigning type of diabetes, diabetes mellitus, the use of insulin, overdose of insulin due to a pump failure, secondary diabetes mellitus, what that is. So definitely here on page 497, put a Post-it note. This is how you code diabetes mellitus. So let me see if we've got our type of diabetes. So these start with the E codes. And over here in your book, so back to the 321 Code It book, just keep your coding manual open. Open. So we have endocrine, nutritional, metabolic. So we have diseases of the thyroid gland, diabetes mellitus, other disorders of glucose regulation and pancreatic internal secretion, disorders of other endocrine glands. And we can code the following. We can code intraoperative complications of the endocrine system, malnutrition, other deficiencies, overweight, obesity, other hyperalimentation, metabolic disorders, and post-procedural endocrine and metabolic complications. Let's go back one. So over here on page 133 of your 321 Code It, says coding diabetes mellitus. There's a big, huge coding tip. It says, if the patient's record documents the administration of insulin, do not assume that the patient is a type 1 diabetic. The provider must document type 1 in order to assign that code. So that's a big deal, and it's different from the way we did it before. So type 1 has to be, because the patient's body is actually unable to produce insulin. And that's why they get the insulin, right? Type 2 diabetes mellitus is the patient's body is unable to properly use insulin produced. So it could be insulin resistant. So again, cannot assume the patient is diabetic 1 because there's insulin there. Okay. Oh, review the patient's record to identify any disease complication Don't forget to assign a code to document any manifestations like diabetic cataract, and make sure you are sequencing the diabetes mellitus first. It is always coded first. So this is a complete discussion here. Actually, it's just the listing of diabetes mellitus I've already showed you in the book on page 133, 134. Okay. You have 5 little homework assignments here. Underline the main term, which diagnosis and statement, and assign the code. So you have 5 there. This then takes us to Chapter 5, Mental, Behavioral, and Neurodevelopmental Disorders, F001 through F99. Literally classifies orders known due to be known physiological conditions, mental health and behavior disorders due to psychoactive substance abuse or use, schizophrenia, schizotypical, and delusional and other non-mood psychotic disorders, mood affective disorders. You have under there anxiety, behavioral syndrome associated with psychological, physiological disturbances, physical factors, disorders of adult personality, mental retardation, pervasive and specific developmental disorders, behaviors and emotional disorders, and unspecified mental disorders. Gives you a complete list here. Let's go over here to Chapter 5 in your coding manual. It's pretty in purple. So starting here, these are what we call the F codes. Includes disorders of psychological development, excludes symptoms, signs, and abnormal clinical lab findings not elsewhere classified. So it tells you what this chapter contains. We just read it. You see in the red, look at F02, dementia and other diseases classified elsewhere. It says code first the underlying physiological conditions such as, and then you see the little arrow pointing. So I includes major neurocognitive disorder and other diseases like those. So anytime you see that, it's going to be revised text. Okay, revised text, Chapter 5. Sort of a short group here of, now this is where the DSM, if there's another coding system that the physicians and psychologists like to use, but they cannot use it for reimbursement. This is only coding for reimbursement. Now again, there could be other reasons. Could be another payer will accept those codes. So exercise 4.6 is endocrine, nutritional, and metabolic diseases. And then we did those. And then exercise 4.7 is 5 for mental, behavioral, and neurodevelopmental. So you probably figured out the pattern by now that you're going to be doing about at least 5 little exercises looking up at the end of each chapter. That's why we're not doing it really in the webcast, because you're going to be doing it for the homework. Okay, Chapter 6 is diseases of the nervous system, inflammatory diseases, systemic atrophies, movement disorders, other degenerative disease, and classifies episodic paroxysmal diseases, nerve disorders, polyneuropathies, diseases of the myoneural junction and muscle, cerebral palsy and other paralytic syndromes are here, and other disorders of the nervous system. Let me go back one. So again, in your coding manual, now you're in the orange section, Chapter 6, Diseases of the Nervous System. And these are G codes, G00 to G99. gives you some specific coding guidelines here. Again, you're expected to read them and be guided by them. No reason to read them to you. I know you can read them yourself. And then you complete exercise 4.8, which is look up 5 ICD-10 codes for the diseases of the nervous system. Is there something I wanted to show you on this? Is this the one? Pain category B is G89. And from there you have to code some age-related issues under pain. So pain does have some of its own information here. And that starts on page 539 of your coding manual. Short section only has, it looks like 10 pages maybe. Okay. So chapter 7 is diseases of the eye, the adnexa, H00 through H59. Disorders of the eyelid and lacrimal system, conjunctiva. We've got the corneas issue, cornea, iris, ciliary body, sclera, lens, and the retina. The glaucoma is here. So I'm on page 139 and 140 of your 321 code it. See that? So any type of visual disturbances, blindness, disorders, issues with the optic nerve, visual pathways, intraoperative post-procedural complications is all going to be covered here in the green section. So I'm over here on page 559 of your ICD-10 manual, tabular list. This is the eye and adnexa. Note, it says use an external cause code following the code for the eye condition, if applicable, to identify the cause of the eye condition. Okay. So it gives you a note here on the top of page 140, assigning glaucoma codes. Assign as many codes from category H40 glaucoma as needed to identify the type of glaucoma on the affected eye and the glaucoma stage. So you have to know which eye and what stage. Bilateral with the same type and stage, bilateral with different types of stages. Okay, so this is a specific guideline right here on coding glaucoma and what has to be documented so that you can code it. So you might want to put a, post-it note that says glaucoma. So exercise 4.9, diseases of the eye and adnexa, you have 5 codes to look up there. Here we go. Chapter 8. So we have Chapter 8, diseases of the ear and mastoid process. That's H60 through H95, diseases of the external, middle, and inner ear, other disorders, and then any intraoperative or post-procedural complications. And over here in your book, pretty teal section, blue maybe. And here's what's interesting. I want you to see this. I'm on page 592. I'm on page 592 of your tabular list. Did you notice there's like nothing there? There's no guidelines. It's reserved for future use. You can also take notes there if you'd like to. So sometimes my students go through and identify in their coding manual where the blank space is so they can take notes there. So you know, right, that you can take your coding manuals with you when you do your certification testing. You can either do, AACCA's is all online, so you're doing that at home. But if you, for some reason, are taking the CPC test or the HEMA CCS, whatever the job requires, you get to take your coding manuals with you and anything you've written in them. No post-it notes. So knowing where the blank space is always a good idea. So here's chapter 8. It actually starts on page 593. This is pretty teal color. So in your coding, in your 321 code on page 141, it says chapter-specific guidelines for future use. So there's nothing there either. Not yet. So exercise 4.10 is disease of the ear, and you have 5. And make sure you identify right and left, right? Okay, chapter 9, disease of the circulatory system. This is quite intense, and it's red. How about that? Look at this. This is so nice. Starts with hypertension on page 604. Hypertension on page 604. You see that? Yeah? Okay. And then we can code, this is I00 through I99. Chronic rheumatic heart disease, hypertension, ischemic heart disease, pulmonary heart disease, disease of pulmonary circulation, other forms of heart disease, cerebrovascular disease, diseases of arteries, arterioles, and capillaries, veins, and other unspecified disorders. Okay. See if this picture is there. Oops. No picture. Okay. So what I'm looking at is on page 142 of your 321 code. Gives you the specific chapter-specific coding guidelines for the circulatory system. Figure 4-7 is signs of congestive heart failure. Yep, congestive heart failure. Hypertension with heart disease, this is under hypertension. Hypertension with heart disease, hypertensive chronic kidney disease, hypertensive heart and chronic kidney disease, just all the hypertensive goes with what? Hypertension secondary, hypertension controlled, hypertension transient. So these are your chapter specific, these are your circulatory guidelines, and it's mainly hypertension. But we also have atherosclerotic coronary artery disease and angina sequela. We have that there. Myocardial infarction guideline is on page 145. So ST elevation, myocardial infarction, STEMI, and non-ST elevation, myocardial infection, non-STEMI and STEMI. So now we can really code these specifically. We could not do that nearly as well with ICD-9. Try not to use the myocardial infarction unspecified site. It is the default, but it's non-specific. So I'm on page 145. And here in your guideline, code I21.3. If only STEMI or transmural MI without the site is documented, query the provider. Don't use this non-specific code. And it doesn't end in 9, it ends in 3. So again, anything that says non-specific or not elsewhere classified, you're not going to use that code. Please don't send that to Medicare. It gives them the excuse to not pay you correctly. Okay, then exercise 4.11 is disease of circulatory system. You have 5 assignments there. 5 codes. Chapter 10, we're getting there. We're roughly halfway there. This is diseases of the respiratory system, J00 through J99. These are the J codes. Acute upper respiratory infections, influenza, pneumonia, other diseases of upper respiratory, chronic lower respiratory diseases, lung diseases. We then have other diseases of the pleura, other diseases of the respiratory system list here. I go back one. Okay, so on page 146, we're on page 146 in your 321 code. We are in your coding manual. It goes from very, very beautiful blood red, cherry red, to yellow, gold, yellow. So, chapter 10, diseases of the respiratory system, on page 642. 642 of your tabular list ICD-10 coding manual. And again, short list, only 5 or 6 pages. So chapter-specific guidelines with coding examples. And then your codes. So that's what's really cool about this new book. Your coding guidelines are in the front of the chapter. Okay? You also have them here in your book, 146, 147. Now, influenza gives you a coding guideline, influenza due to certain identified influenza viruses. So I want you to highlight this or put a post-it note on or something. So code only confirmed cases of influenza due to certain identified viruses. That's category J09. So if you turn over in the book with me, coding manual, J09, it's on page 645 of your coding manual. Do you see that? I literally have books all across my desk. I kind of lean over. Now I'm trying to find my book. Okay, so J09, and it says it excludes influenza due to other identified influenza virus. J10 excludes J11, an unidentified influenza virus. Seasonal influenza, due to other identified influenza, that's J10, and then J11 again, seasonal influenza. So influenza due to certain identified would be like J09.X, avian or bird flu, or AH5N1 swine flu, and then you go up to the top of the page, J09.X1 due to pneumonia. Code also, if applicable, associated lung abscess or other specified type. J09.X2, other respiratory manifestations. X3, gastrointestinal manifestations. And X9 due to identified novel influenza A virus and other manifestations. Okay. So the reason I went over that very specifically with you is because we're having some problems in the data. We're having to make sure that this is coded correctly. All the claims are going back. CDC issued some type of a warning late last year that they were having issues with this coding. So I want you to identify this in your manual with a post-it note so you can find it easily. So again, this is influenza due to certain identified influenza viruses. Okay? That's on page 147 of your 321 coded as well. So exercise 412, diseases of respiratory. You have five. Wow, where is my connection? Thomas is there. Hello, hello. Transmission stopped due to slow internet. Am I coming back? Sorry about that. I don't know. Internet connection was too slow to pick up the video. I don't know. Sorry. Okay. Chapter 11, diseases of the digestive system. We are on page 149 of the 321 coded book, and this pretty purple section of the K codes. We've looked at them before. Look at that, up there, a page with nothing on it. 656. Look at that. Put a post-it note. You might need it for something. You never know. You can put anything on your book that you want in case you're taking it somewhere. They can't rip your pages out. We've gone through all this with AHIMA and mainly with CPC because those are proctored by humans, different humans. It's best to not let them know you're a nurse. I know. I wouldn't if I were you. Just go through the program, okay? If you want that CPC credential, just go get it and get it quietly, okay? Okay, so in the pretty purple section on 657, disease of the digestive system, K00 through K95. We've kind of already looked at some of this, but diseases of the oral cavity and salivary glands, because you know the digestive system starts right here, right? Esophagus, stomach, duodenum, appendix, hernia, non-infective enteritis, and colitis. All of that is in here. Intestines, peritoneum, liver, gallbladder, biliary tract, pancreas. Okay, so over here on page 148 of your 321 Code It, are you with me on this page? It says the alimentary tract or digestive tract is long muscular tube. Yes, we know that. And it just gives you the list here in case you need to review your anatomy. It's right here. So example, the following are examples of diseases that interfere with digestive function, and they are classified in Chapter 11. So dental caries. A lot of people don't realize that tooth decay, can be an issue. For other parts of the body, you would assign code K02.9 as a direct effect on digestion because the disease process interferes with mastication, obviously the breakdown of food by chewing. So dental caries are important to be documented. Why is that? Because we know that it can be implicated in problems with the heart, with MIs, right? So portal hypertension is over here. K76.6 is high blood pressure of the liver's portal circulatory system. So that can actually be, it can actually affect, it doesn't directly affect hypertension or digestion, but portal hypertension has no apparent effect on the digestive process that we know. But it can be an issue of cirrhosis of the liver, correct? And other conditions that cause obstruction to the portal vein, such as cancer. So that's why we want to document that. So here we are at the top of page 149 with no guidelines at this time. So don't have to read those because they're not there. But you do have to do exercise 4.13, diseases of the digestive system. You have 5 codes to look up there. Remember, you're going to start with your alphabetic index. And now canker sore is kind of interesting. Not only is it a very annoying situation, but what word would you start with in your index? I'm on page 149. Let's figure that out. So I would go to sore. Let's see if that works. I'm on rupture. That's not it. So it's a sore. It's something there. And it's on page, it's on page 286 of your index, alphabetic index, in your ICD-10. Sore, bed sore, desert sore, eyesore, mouth, canker, there it is. So, sore, mouth, canker sends you over to K12.0. What if you looked up canker instead? Let's just try. That's why it's important to know which word you're looking for. So the book will send you on a wild goose chase if you let it. I don't think we can code wild goose chase. Okay, let's see. Canker. Should be in here actually. C-A-N. Calculus. C-A-N-K-D. Canker. There it is. Canker on page 47. So it didn't matter in this case which word you looked up. You would get there. Canker, parentheses mouth, parentheses sore, K12.0. How about that? Okay. So just so you know. Okay, we're going to chapter 12. Diseases of the skin and subcutaneous tissue, L00 through L99, the L codes. Infectious of the skin and subcutaneous tissue, bullous disorders, dermatitis, eczema, the papulosquamous disorders, urticaria and erythema. Radiation-related disorders of the skin, disorders of skin appendages, intraoperative post-procedural complications. So I'm on page 149 in your 321 Codit. I am back here on chapter, there's 13, chapter 12. Yes, chapter 12 is the orange section. I want you to find that. Maybe put a post-it note on it. Okay, so on page 678 of your ICD-10 tabular list is the coding guidelines with coding examples. That's what's cool. Coding examples right here. So it's important that you read through this. They're provided along with these guidelines or coding examples contained in the shaded boxes, the pretty purple boxes that have been developed to help illustrate the coding and or sequencing guidelines found in this section. You see that? So we actually have guidelines in this section. So as you go through on page 149 and 150, you will see these, and the one I want to show you is the pressure ulcer stages codes. Nurses are often responsible for measuring the depth and how it's spread and this, that, the other of the pressure stage of the ulcer. So starting on page 149 and continuing on 150, you have a variety of information here of guidelines, and it should be over here. I'm still looking on my guidelines here. So pressure stage ulcer codes. Very, very good information. We did not have this. We had some of it. But I want you to know nurses had a lot to do with developing this information because they're the ones providing the care, right? Dressings. Okay. So you'll have a lot of stuff in right here with the skin. But over here on L09, if you look on page 687 of your coding manual, it's got some really cool illustrations that you're probably already familiar with. Under pressure ulcer, L89, includes bed sore, decubitus ulcer, plaster ulcer, pressure area, pressure sore. Code first any associated gangrene, I-96. Okay, there's a note there. Bright red. So these are the 4 stages of the pressure ulcer. This comes in real handy, especially for your non-clinical people who are trying to do this coding. But for you guys, it should be fairly simple, especially if you've done this nursing care before. So we can actually code right and left here. We can code unstageable. So it's something that's unstageable. Gives you some information here on page 150. Again, it's also in your coding manual. But an unstageable pressure ulcer assignment of the code for unstageable, L89, should be based on the clinical documentation. That's where we get that. These codes are used for pressure ulcers whose stage cannot be clinically determined, like an ulcer is covered by scar tissue. Maybe it's been treated with a graft of some kind. And pressure ulcers that are documented as a deep tissue injury, but not documented as due to trauma. So this code should not be confused with codes of the unspecified stage. So when there's no documentation regarding the stage of the pressure ulcer, assign the appropriate code. I would go and get more information than that, though, before I did that. There's always more information somewhere. Okay. So you have 5 little exercises here. So decubitus, number 3 is decubitus ulcer. What are you going to look up first? Ulcer. Okay. Chapter 13, diseases, the musculoskeletal system and connective tissue. These are the M codes. M rhymes with skeletal, right? Muscle. M00, M99. We have infectious arthropathies, inflammatory polyarthropathies. We have osteoarthritis and other joint disorders. We have also dental facial anomalies like a malocclusion, disorders of the jaw, systemic connective tissue disorders, deforming dorsopathies and the spondylopathies, and okay, got all those there. So disorders of the muscles, disorders of the synovium and tendon, other soft tissue disorders, disorders of the bone density, other osteopathies, and as you go down the list, biomechanical lesions not elsewhere classified. Where was that? So yes, we're going to add some more time here. Going to add 30 minutes. Don't know if that'll help me or not. We're getting there. We're on chapter 13 out of 20 or 21, right? So gives you an example here, just on page 151. Patient is diagnosed with degenerative joint disease, bilateral knees, and you would assign ICD-10-CM M17.0 bilateral osteoarthritis of the knee. So that gives you one code for both knees when it's reported as bilateral. Okay? So your specific guidelines, let's go over here to chapter 13, bright green again. So in your coding manual on page 697 are your coding guidelines and coding examples, which are really cool in this book. If you turn the page, you'll see on page 698 the muscle tendon table. Starts with the body region like shoulder, shows you the muscle, the extensor tendon, the flexor tendon, and the other tendons. So that's why this is an extremely good way, upper and lower extremities and by their action, like extension or flexion, and their anatomic location. So please note that this table is not all-inclusive, and proper code assignment should be based on the provider's documentation. But this is a new table. We didn't have this before. It makes this coding much simpler, much straightforward, because it reminds you what else you're going to need to look for in the documentation in order to get to the code. Okay? So then the chapter starts, chapter 13, starts on page 781. Nope, sorry, I'm not reading it right. 701, sorry, 701. Let's go back one. So we're on page 151 of your 321 Code It. And your specific, chapter-specific guidelines are also given here. At the very top of page 152, number 1, it says bone versus joint. I want you to circle that or highlight it or however you want to look at it. For certain conditions, the bone may be affected at the upper or lower end. Gives you an example there, osteoporosis, M80, M81. Though the portion of the bone affected may be at the joint, the site designation will be the bone, not the joint. So I'm going to highlight that. It will come in handy for you to remember that. And again, that's in your coding guidelines, acute traumatic versus chronic or recurrent, coding of pathological fractures. Now, pathological fractures would be caused by something like bone metastases. Remember I made that comment that in the EDs, when we were talking about the little old lady who was reporting to you, she had been a fractured femur, but it was a car accident that caused the fractured femur. Remember we were talking about breast cancer survivor and stuff. So 7th character A is for use as long as the patient is receiving active treatment of the fracture. While the patient may be seen by a new or different provider over the course of treatment for a pathological fracture, assignment of the seventh character is based on whether the patient is undergoing active treatment and not whether the provider is seeing the patient for the first time. So very important distinction there. We're really trying to, that's been an issue for CDC. We're really trying to identify the treatment of the pathological fracture. So as long as they're in active treatment, you're going to be assigning the seventh character A. Doesn't matter what the provider is. So D is used for the encounter after the patient has completed the active treatment, and the other seven characters are listed under each subcategory. Osteoporosis, we're trying to keep track of that for men as well. We know we're tracking it for women. Of course we are. So osteoporosis without pathological fracture or with current pathological fracture. So keep track of that. So top of page 153 is diseases of musculoskeletal connective tissue. You have 5. And we have something called the kissing spine. Kissing spine. What would you look up in your, it's one of my favorite. What would you look up in your alphabetic index? Oh, let's just look up kissing and see what we find, okay? So look up the term kissing. I don't write this stuff, you guys. So I-J-K, wait a minute, I flipped Parkinson's. See, when you look stuff up like this, you never forget it. Oh, okay, kissing. Oh, I found it. Kissing spine. It's on page 204 on the lower left column. Kissing spine, M48.20. And you have to know the region of the spine to code it correctly. So is it cervical, thoracic, lumbar, lumbosacral, thoracic region? Kissing spine. I hope you wrote that down real quick. It was in your assignment. Okay. Clawfoot, that's cool. Okay. So, chapter 14 is diseases of the genitourinary system. Okay. So we start with the urinary system, acute kidney failure, chronic kidney disease. We'll look at that in a minute. Diseases of the male genital organs, disorders of the breast are in here. Inflammatory disease of the pelvic organs, the female. So in your tabular list, chapter 14, pretty blue section. Very, very pretty blue. So it starts on page 701. There's a little bit of white space, in case you want to mark it. On page 780 and 781. So you have specific guidelines here on page 781 of your manual. Chronic kidney disease, stages of chronic kidney disease, and then chronic kidney disease and kidney transplant status, and then chronic kidney disease with other conditions. So, very specific documentation has to be done for this. Very important that we're tracking the chronic kidney disease with the ESRD. It has to be documented, the end-stage renal disease, and how we're going to code these. So these are the N00 through N99 N codes. chronic kidney disease, kidney transplant status, current kidney disease, and other conditions. Okay, so as you go through this, oops, lost it. As you go through this section, you do have those 5 things to look up. But in this blue section, I just want you to see how it's arranged here. We have a lot of green type in here this year. And what it's doing is, so look under N03. See N03? Okay. Chronic is green. Chronic nephritis syndrome, what it includes, what it excludes. And then N03.0 is minor glomerular abnormalities. So see how the green type actually shows you exactly what you have to have in the diagnostic statement or in the chart so that you can code it more specifically. We have a lot of that in here this year. A lot of really good information. Now, if you look on N008, glomerular disorders and diseases classified elsewhere, it's highlighted with that blue tint, and that is a manifestation diagnosis when you see that. So I want you to identify that in your book. Highlight it or not highlight it, but, just make a note there. So anything that has that light blue is a manifestation diagnosis, which means that it is coded secondary, right? So you have nephritis, nephropathy, code first the underlying disease, such as the congenital syphilis, the gout, the sepsis, the sickle cell. Okay, so be on the lookout for these light blue highlighted codes, because those are always manifestations, which means they're always secondary. Okay? Code first. The underlying disease. Okay, so then you have 5 exercises to do with the genitourinary system. That takes us to chapter 15, which is my favorite. Pregnancy, childbirth, and the puerperium, which is postpartum. This is the fun part. They're O00 through O9A. I don't think that's a good idea, but whatever. Now, these are from maternal records only. Very important that you know that. Maternal records only, which means they can't ever appear on a newborn record. Okay. You would be surprised at how many mistakes are made this past year. I had to do a special at the MANA conference last year. MANA is Midwifery Alliance of North America. I had to do a special coding class just so they understood the difference, because the midwives aren't doing the coding. They should be. They're the clinical person, right? So I had to make sure that the midwives were really understanding of what this was so they could check over things. And in case some of them are still getting paid by insurance, which I don't think they are, they could at least help the hospitals with that, or the OBs, whoever they're working with. Okay, so on page 155 of your book, 321 Code It. Let me do something here. We are in the O codes, bright cherry red. In your coding manual on page 798, you have quite a few guidelines here. We have 1, 2, 3, almost 3.5 pages full of guidelines over here in coding, like selection of OB principle and first list of diagnosis, all that is there in your coding manual. And what is included in this section are related to or are aggravated by pregnancy, childbirth, and postpartum, and considered maternal causes or obstetric causes. So what's interesting about how we do this now, which we didn't do it before, never had the chance to code it this way, is trimesters are counted from the first day of the last menstrual period if known and are defined as, okay, so these are the official definitions now. First trimester is less than 14 weeks, 0 days. Second trimester is 14 weeks, 0 days to less than 28 weeks, 0 days. Third trimester is 28 weeks, 0 days until delivery. You would also use an additional code from category Z3A. Let's look that up. Category Z3A, or back in the back of your coding manual, in the Z codes, which are factors influencing health status and contact with health services. So Z3A hold on to this book, and this is a big section. Z3, Z, not Z-O, Z3. Z3A to identify specific week of pregnancy. Hang on. Z000001. That should be in here. It must be a category because it's not in. There's Z12. See, this Z, it wants to go to Z03 in your book. Encounter for medical observation for suspected diseases. That's not it. Okay, so here's what I'm going to show you how to do. Let me find it. It's on my little post-it. I have my little card that I keep right above my thing. So this is called the gestationalagecalculator.com. I kid you not. www.gestationalagecalculator.com for ICD-10 Global Maternity Care Coding. Now, in order to use this correctly, you need the due date and the date of service. So again, this is not your book, something purely that I do. So see, all I have is right here. It's my little gestational age calculator. Okay? For global maternity care coding, you need the due date and the date of service for this. So we're not going to go look it up right now, but I want you to have it. Okay, so we're going to put this back up here. Okay. So pregnancy with an abortive outcome goes O00- to O02. However, when complications of an ectopic pregnancy occur, assign a code from category O08 so that we can track that it was an ectopic or a molar pregnancy. When fetal complications are documented as a causal factor in an abortion, 2 codes are assigned. So if for some reason one code is for the abortion, the second code is for the fetal complication. Okay. We have complications of labor and delivery. When a patient experiences a delivery and antepartum or postpartum condition during the same encounter, you assign 2 separate codes. On page 155 of your book, 321 code it. So here's an example. Patient is discharged from the hospital with a diagnosis of ablatio placenta, pregnancy of term, 3rd trimester, delivery, and delayed postpartum bleed. So you would code O45.93 and O72.2 are assigned. Also report the appropriate code from category Z37. So let's go back here. We may find this again. Z37. There they are. So Z3A, 11 on page 1152 in your book. So we just went back here. Let's go back real quick and show you where this is. So it says use additional code from category Z3A. There it is. Z3A weeks of gestation codes from category Z3A are for use only on the maternal record, indicate the weeks of gestation of the pregnancy if known. So that's new. New information is right there. Okay, so then you have weeks of gestation of pregnancy unspecified. That's that's no good. We have to have the weeks. So this just shows you how to code the weeks. But I really like my little calculator because it's quicker. You got to have the due date and you have to have the today's date, which is the date of the encounter. Okay. Then Z37 is outcome of delivery. Do you see that? And it says, and both of these it says Z3A you have to have fourth, check fourth, and on Z3A.0 you have to have a fifth. So those little tiny boxes will always tell you how many digits you've got to have to make this correct. So Z37 has check fourth and a note. This category is intended for use of additional code to identify the outcome of delivery on the mother's record. Okay. So single live birth is Z37.0. And then if you have a single stillbirth or you have twins, both live born, you have other births, all live born. You have some live born. We're much more, we're just much better at this now that we have 10, that we can track all this, especially when we have multiple babies on board. Some of them make it, some of them don't. All of them make it. None of them make it. We can actually code all of this now. Okay? So there's your Z codes. Normal delivery. So I want to show you lots of stuff here. Your information for your guidelines start on page 156, go to 157, 158, 159, and 160. These are the guidelines for OB, for the mother's care. One thing that we're tracking now as midwives and as labor delivery nurses and hopefully OBs for abuse in a pregnant patient. Abuse in a pregnant patient. This is at the bottom of page 160. For suspected or confirmed cases of abuse of a pregnant patient, codes from subcategories 09A.3 physical abuse complications, 09A.4 sexual abuse complications, and 09A.5 psychological abuse complicating pregnancy, followed by the appropriate codes if applicable. So fortunately I've never had, well I shouldn't say never, I've hardly ever had to get into this. But it tells you at the bottom, see section I.C.19.F, adult and child abuse, neglect, or other maltreatment. So it's something that you need to be aware of. I'm sure that if you're in that situation, you're already aware of a duty to report. I had to do a class for the midwives to help them understand that we have a way to not only, code this, but to track it. And that we also have a duty to report. So, top of page 161, you have pregnancy, childbirth, and the puerperium. Wait a second, there's something else I want to show you. Is it in a Z? It might be in a Z. Gestation, pregnancy test, supervision of normal pregnancy is Z34. It's pretty much the only one I use. Well, I think that's in HCPCS. I'm going to show you in another chapter how we track what type of delivery she had outside of hospital. Okay, so we're going to chapter 16 at this time. Conditions originating in the perinatal period. So back to, we're in chapter 16, verse 19. That's a big section because it's injuries. Okay, chapter 15, something I did want to show you in 15. I'm sorry. Go back for a second. I forgot that was in here. Okay, so on page 824, 068, 060, 060.1, preterm labor with preterm delivery. And you identify the number of fetuses, which fetus, in case you need to. Term delivery with preterm labor, 060.2, you identify the fetus with the 7th character. And then if you go to the next page, 064, obstructed labor due to malposition, malpresentation of fetus, gives you some illustrations of a breech, face, compound, oblique, and shoulder with a arm prolapse, and then it gives you again the 7th character identifies the fetus, which one, in case there are multiple ones. So that was something new, and then that also is over on 069, which is on page 826. Labor and delivery complicated by umbilical cord complications. Again, identifies, if necessary, which fetus. Okay? New stuff every year. Okay, over on page, chapter 16 on page 835 of your coding manual. We are on page 161 of your 321 Code It. Just keeping our books straight here. It's not easy for me either. I have to be very specific with what I'm sharing with you. So P00 through P96, these are for newborn records only. So make sure you write that in your book. I can't tell you how many mistakes I've seen on this. Newborn only. Okay. Starts on page 835 of your coding manual. Here are your coding guidelines on those first 2 pages. Chapter-specific coding guidelines. And this chapter classifies conditions that begin during the perinatal period, even if death or morbidity occurs later. The perinatal period is that interval of time occurring before, during, and up to 28 days following birth. Okay, the perinatal period. And these codes classify causes of morbidity and mortality in the fetus or newborn. Additional codes can be assigned from other ICD-10-CM chapters. Okay, so I want to share something with you that I want you to be on the lookout for in family or facility or wherever you're seeing this. So as a midwife, we're aware, we kind of hang out with midwives in other countries at our conferences. And in February, the Australian Midwife College reported a very disturbing trend in their country, something for others to be, aware of. So they have girls getting. Oh, I'm almost there. Hello. Sorry about that. Lost internet. I don't know. Somebody burped. I don't know. Your Wi-Fi is intermittent at best. That's why when you're taking your AACCA exam also on WizIQ, we ask you to write down your answers. So just in case it gets interrupted, just like it did, you'll have your answers and you can log out, log back in, put your answers in, and keep on going because the clock resets, so you don't have to worry about your time. Okay. So, don't know what that is. So again, newborn records only. Perinatal period is before birth through the first 28 days after birth, even if the morbidity occurs later. Let's go back one. So I want to show you here on page 162 of your 321 Code It. You have certain conditions originating in the perinatal period, and yes, we're going to have to do this by about 25 minutes, maybe less. Losing connection doesn't help. Hopefully you're all still there. I won't know until we finish, right? Looks like you're all still there. So, bacterial sepsis in the newborn, low birth weight, immaturity status, prematurity, and fetal growth retardation. These issues are coding additional perinatal diagnoses. So you're assigning codes for conditions that require treatment, codes for conditions specified as having implications for future health needs, So prematurity and fetal growth retardation are big issues. We're trying to track that. Low birth weight and immaturity status. Category P07, disorders of newborn related to short gestation. I gave birth to two, not one, two premature baby boys, 10 years apart. Thank God for Loma Linda University Medical Center in 87. They were the only ones, except UCLA, with a level 3 NICU. And I made the OB in charge of my case transfer me to Loma Linda. And he said, but I can't go with you. And I go, so what? I want my baby born at Loma Linda if he has a chance of surviving and we were hoping to get the labor stopped, but he was born 9 weeks premature. He was 2.5 pounds. And there was nothing wrong with him. He was little, but there was nothing wrong with him. So plenty of breast milk. And I was able to take a consulting job with a doctor out there near the hospital. And I told him, I said, I'll turn your computer back on. I'll get all your Medicaid stuff filed and I'll get all your money, but I have to go over here and be with my son and 3 or 4 times a day. I said, I'll get your stuff done. You don't have to worry about that. You'll have more money than you know what to do with. But I'm going over to take care of my son. So I spent a lot of time with him. I would take him out of the isolate. I would dress him, take him out, rock him, breastfeed him, sort of. And, it's hard when your boobs are bigger than their head. It's a little difficult. So you have to do the little, the lavage. So he was out in 4 weeks. They usually tell you you're going to keep him at least the 9 weeks to finish the gestation period. I had him out in 4 weeks because first of all, I had hit 5 pounds. And second of all, I was having to break in a new neonatologist in the next, and I didn't want to be bothered with that. It's hard enough training them when you have a month. So I said, well, he's hit 5 pounds. So that got me into a home visit with the social worker. And they also tracked him for this low birth weight, slow growth. And they discovered that he was, because I was breastfeeding him, he was over the curve. And Loma Linda, you probably don't know, but Loma Linda is a Seventh-day Adventist, which makes them vegetarian, which makes them very pro-breastfeeding, which is really cool. And they were using information from his case and some others in the local area. They said, your babies are thriving, and we need to figure out why. And I said, well, I can tell you right now, it's breastfeeding. He's exclusively breastfed. I was exclusively breastfed, and in the 50s, that was pretty odd. My mother breastfed me straight for 9 months, and she had so much trouble, not with me, but with the public at large, which we're still having problems with these days. But it just restricted her activity so much, and it really restricted her. She was only 21 or 22 when she had me, so it was hard for her to do that. So 2 years later, she had my brother put him straight on the bottle, and it really changed our ongoing development. It really did. They didn't know that in the 50s, but we do know that now. So obviously, I don't take on clients unless they're willing to breastfeed. It's not worth it to me to have all the problems that I know they're going to have. My brother had allergies. He had serious problems with his teeth. He's 62 now. He's had issues with digestive and with diabetes. And I just don't have those issues, so who knows? So, again, tracking through the perinatal period. We're also tracking bacterial sepsis, P36. And this includes congenital sepsis. Oh, my second preemie, my 6-weeker, his name is Jordan Avery Thomas. He is almost 20 years old on Monday. He does extremely well. He was almost twice as big as his brother at birth. But I got into it with a nurse in the nursery. I was in a different hospital. And I had a sign on the isolate that said, breastfed baby, do not bottle feed. Mother comes in. I had it on both sides and both ends, and everybody had been told. I was, my milk was coming in. I was post-op. I was supposed to be driving. I was driving anyway. And I know I'm one of those. I know. So, came in and she was rocking him with a bottle in his mouth. I'm not kidding you. I almost killed her. I'm not kidding. I came after her And I said, give me the baby now. I said, we're out of here. I said, can't you read English? I said, what is your problem? Well, he wasn't comfortable. I said, can you not read English? I was on my way in. Please don't do that to your lactating mothers. Please don't do that. One of them might not get caught in time before she strangles you. I said, I'm out of here. I said, write it up. Oh, you're going against, I don't care. Write it up. We're out of here. I said, you people can't speak English. We're done. That's not what it was, That's what I latched onto. I'm post-op. I'm also postpartum, and I have hormones, God knows where. And she was bottle feeding my baby when my milk had come in. Okay. That was 20 years ago, and it still pisses me off. Okay. So you're going to do your 5 here, your 5 little exercises here. That will take us to chapter 17. And those are hang on a second, what's our pretty purple ones again? We got purple over here. So that takes us to 847, chapter 17 in your ICD-10 manuals. And at the top of page 164, do you have that? Page 164. Congenital malformations, deformations, chromosomal abnormalities. These are the Q codes, Q00 through Q99. These are not for use on maternal or fetal records. Not going to use them at that time. So these classify the following congenital malformations. And it gives you some examples here. We have malformations in nervous system, eye, ear, face, neck, congenital malformation, circulatory system, respiratory, and cleft lip, cleft palate is here, malformations, genital organs, urinary systems, musculoskeletal, chromosomal abnormalities not elsewhere classified. So back one. Okay. So let me give you an example here on page 164. Thalidomide. The phocomelia results from influence of the drug thalidomide on the developing fetus during the prenatal period. Now, thalidomide babies were born elsewhere. They were not born in the United States. Do you know why? Because one female physician in the FDA stood up and said, no, I don't understand this. I'm seeing this information in other countries. No, I'm not going to approve it in the United States. One female physician stood up and said no. All right. So this thalidomide then is a congenital birth defect. The reason why we code it in ICD-10 is we're seeing these babies are, now they're in their 30s and 40s now, but we're seeing these babies coming in from other countries. Thalidomide is still banned in the United States. So congenital absence of upper arm and forearm, hand present, bilateral. So this is how you're going to be coding this type of abnormality if you see it. So it tells you here that ICD-10 does not differentiate. I'm still on page 164 of your 321 code. Does not differentiate between intrinsic abnormalities, defects related to the fetus, or extrinsic abnormalities. These are defects that are a result of intrauterine problems. ICD-10-CM also does not make a distinction in the classification of an anomaly as compared to a deformity. So anomaly is a malformation caused by an abnormal fetal development, like transposition of the great vessels or spina bifida. Deformity is an alteration of the structure caused by an extrinsic force, like intrauterine compression, for example. So the force may cause a disruption in the normal fetal structure, including congenital amputations from amniotic bands. Some cases assigning 2 codes is necessary to describe the condition. So this is how we actually do this. Again, this is for the newborns. So you do have some, over here you have, on page 846 of your big, huge coding manual. We do have some coding guidelines here. And, of course, they are also discussed here in your book on page 164 and 165. But obviously the most definitive information is going to be in your coding manual, right? So you have 5 examples here, 5 codes to look up on page 165, exercise 4.19. Make sure you're doing this in your activity list on your MindTap for credit. Takes us to chapter 18, sort of the bane of my existence. I hate chapter 18. It's absolutely necessary to have it. These are the R codes. I don't like seeing R codes on claim forms, so make sure I don't. Now, I know you're not my employees, and I know someday you might be actually working for our Encoder Virtual Office. So just because you can code it doesn't mean you should code it, right? So, signs, symptoms, abnormal results from clinical or other investigative procedures, ill-defined conditions with no diagnosis classified elsewhere. You cannot get claims paid with these things. I don't even know why they're in here. It's very annoying. But you need something to sometimes describe why you're seeing the patient, and you don't quite have, it's this orange section here. You don't quite have enough information yet. Okay, so over here on page, starts on page 165, gives you some examples here. Like, here's an example. Patient was admitted with right lower quadrant abdominal pain. Pelvic ultrasound was negative. So why not do an abdominal ultrasound? Anyway, you assign code R10.31 because the provider did not document a definitive diagnosis. What are you supposed to do with that? You go back to the provider to clarify the documentation, right? So also report as principal diagnosis any symptom, sign, or abnormal finding that's associated with contrasting or comparative diagnosis, like sign or symptom associated with two or more suspected or possible diagnosis. You report the contrasting or comparative diagnosis as other additional diagnosis codes. So, chest pain. So a patient was admitted for treatment of severe chest pain. The provider documented severe chest pain due to acute myocardial infarction versus hiatal hernia. Okay. Assign code RO7.9 chest pain as a principal diagnosis. Assign code I21.3 as acute MI as other. Okay. I don't like that. I do not like anything when chest pain is reported. We're going to go through a certain set of procedures, correct? We're going to pull some blood for troponins. We're going to hook them up to an EKG machine. We're going to start watching stuff, right? So when I see a physician do that, MI versus anything gastrointestinal, whatever, I'm like, no, I don't want to see that. I want to see the results of these tests. And then I want you to pull it together and give me a definitive diagnosis, because I can't report this and get you paid. As long as you help them keep in mind what they can and cannot report. So assigning the acute MI as an other additional diagnosis code is just insane to me. Now here's the problem with chest pain. It's a symptom, right? It's not a diagnosis. Okay. So just know that in something like chest pain, where we have 5 minutes to get them back there and hooked up and ready to go, right? That's a standard here in California. Is that standard elsewhere? We got 5 minutes to get them back there. We're not going to know what else it could be until we run all the tests. So I'm showing you this example because I don't like it. I think it's a no-no. I think it causes problems with, especially with the non-clinical folk, that they don't really understand what they're looking at. I would go straight back to the provider and say, what is this? Did you get some troponins? You got an EKG? Show me what? I can't code this. I can't get the hospital or the doctor paid with that. So that's why I do probably coding a little differently than everybody else, because I'm always looking on the reimbursement side. I'm always looking on the compliance side. Compliance will always protect you if you do it correctly. So you might as well do it for the reimbursement side. Okay. That's the issue. Okay. So on your page, 863, starting on chapter 18, this is the orange section in your tabular list in your book, your coding manual. You have, chest pain unspecified. Use of symptom code. Don't put it on a claim. Same way with acute gastritis and bleeding, unspecified acute appendicitis. How do you get unspecified acute appendicitis? Or in my father's case, or my son's case, they put abdominal pain. And I told them what code to use. I gave it to them. We can't take codes from you. I don't care. Look it up. I want that code on that claim so it will get paid. Do not send the bill to me. That's what happens, If a bad code goes through to a claim and it gets denied, they don't bother to fix it. They just send the bill to the patient. And the patient doesn't know that they screwed up the code. But I do. And now you do. Okay, so how do you get acute unspecified? Okay. So you have, you have white paper. You have white space on 864. So pretty. Did you know about coding death? You can code a lot of stuff. Now, death NOS. Let's look at this. We're at the very, very top of page 864 on your coding manual. Death not otherwise specified. So it tells you here, code R99. R99? That looks like a test question to me. I don't know. R99, ill-defined and unknown cause of mortality, is only for use in the very limited circumstance when a patient who has already died is brought into an ER or other healthcare facility and is pronounced dead upon arrival. It does not represent the discharge disposition of death. Okay. We never could code death before. Really? There's no code. R99 is pretty limited. So again, under that circumstance, it can be used. I can tell you right now that claim is going to get rejected, and they're going to turn it around and they go, what is the cause of death? Go. Okay. We've got chapter 19 to do. Try to stay out of that section, okay? Please. Makes my job as an auditor that much easier. That's what you guys are here for, is to know how to do this. Okay, so chapter 19, big section. That pretty green. It starts on page 882 of your coding manual. Injury, poisoning, certain other consequences of external causes. These are the S00 through T88. So it classifies injuries of everything. Effects of foreign body entering through a natural orifice. Burns and corrosions are here. Frostbite is here. Poisoning is here. So if you turn in, you've got guidelines starting on page 882, 83, 84, and 85, and then that takes you to that. Remember, we looked at that musculoskeletal tendon table. Okay, so as we go through this is a big section all by itself. Toxic effects of substances. Classifies. Go Go back. Okay, so S00 through T88. Now, there's a coding tip here on page, did I assign exercise 420? Just because I didn't say it doesn't mean you can't do it. So you need to do those 5 and 420. So coding tip, injury and poisoning codes are not assigned for normal healing surgical wounds. Okay? Or to identify complications of surgical wounds. Okay? To classify complications of surgical wounds, refer to main term complication. Look up the word complication in your index, right? Okay. So a fracture, I know it's kind of silly. We have to identify it, though. We have to define a fracture. Is a break in the bone resulting from 2 possible causes, direct or indirect application of undue force, which is an injury, or pathological changes, which is a disease process. So the provider must determine and document whether a fracture is open or closed, which is one of the first determination. A closed fracture, simple fractures contained beneath the skin, has intact ligaments and skin, while an open fracture, of course, is a compound fracture, indicates associated open wound. Okay. So Chapter 19 does not contain codes for the malunion or the non-union, okay, of a fractured bone, which is the failure of the bone ends, of the fractured bone to heal, unite. And such codes are located in Chapter 13 in malunion, non-union of fractured bones, classified in 19 by 7th character. So here's the issue. If there's no documentation in the patient record as to whether a fracture is open or closed, the fracture is coded as closed. So closed is the default code here. Because they didn't tell you that it was open, then it's closed. Okay. So you have a variety of, it gives you a list on page 169, a list of terms that you could be seeing in the charts that the doctors use. It gives you the definitions here, all of which you probably already know. Burns starts on page 169. These are T20 through T32, classified as to depth, which is first degree, second degree, third degree. Over here on page 170 gives you our rule of nines. You have the anterior view and posterior view of adult, and you have the anterior view of the baby. So because the baby's head is unusually large compared to its body, the head and neck is given 18%, while in the adult it's only given 4%. That's a big difference. It's amazing they ever learn how to hold that thing up, huh? Which they do at birth, by the way, if they're not drugged out of their little gourds. Okay, our babies aren't drugged. Adverse effects, poisonings. So let's go back to birds real quick. I'm going to show you in your coding manual. So the burns are him. What's there? Okay. So burns are T20 through T32. So join me at T20. I'm in the green section. T20. T20. Okay. So we're on page 1010. We're on page 1010. We're in your coding manual. See that? Burns and corrosions, T20 through T32, includes burns and corrosions, external body surface specified by site. So we specify by site and percentage. Site and percentage. Give it another 20 minutes. I don't know if you can see those or not. So you have T20, burn of unspecified degree, head, face, and neck. Try not to use that. You need an external cause code. You really basically need two codes for every burn. You need the site and the percentage. First degree gives you the degrees, gives you an idea here with this picture. Burn first degree of lips, chin, nose. So now we have very specific where this is on the face or the body. Gives you that little blue over here on page 11 or 1011, 1011. Gives you the little blue and red boxes. You see those? So the little red boxes check for 5th character. The blue boxes check for 7th character, like burn of 2nd degree of head, face, and neck unspecified. You're going to need a 7th character there. So you see the difference here? We have burns, we have corrosion. Very, very, very specific. Then you go to T21. Go to T21, top of page 1012. Burn and corrosion of trunk includes burns and corrosions of the hip region, and the appropriate 7th character to be added to each code from category T21 is A for initial encounter, D for subsequent encounter, or S for sequela. So that's where you get a 7th character in that. If you reported T21, or any of these T21s without that 7th character, the claim would get rejected. And you would have to do it all over again. So just do it right the first time. Burn units are really good at this coding stuff. If you're if you're a burn unit nurse, you've been doing this for a while. We were doing a lot of this in ICD-9. We're doing it even better and more specifically in ICD-10. We're tracking things better now because of that. So I want to show you, starting on page 170, I'm back to your T21 code it. Adverse effects, poisonings, underdosings, and toxic effects. So we looked at the table of drugs and chemicals very briefly in chapter 3, just as we were going through the book. And I want to show you this. It gives you some coding tips here. It tells you here at the bottom of page 170. Are you with me in your 321? So to locate the code for an adverse effect. So an adverse effect, right, is the situation where the patient has been given the correct dose. Oh, he still had an adverse effect. Correct dose. Okay. So you look up the main term effect in the index, right? And locate the appropriate subterm like drugs or medicines. And then go to the main term or start with the main term reaction. Okay? Reaction. And locate the appropriate subterm like drug, NEC. Then assign the appropriate external cause code from table of drugs. Okay? So let's go to the table of drugs and chemicals. Let me put this in here. No. So table of drugs and chemicals are back here in your index. Starts on page 346 of your ICD-10. So to use this table of drugs and chemicals, you would need to know the drug or chemical, right? You need to know the name. And then as you look that up alphabetically, let's say, let's look up alcohol. And it says grain alcohol. You see that? We're on page 347. I just want to show you how to use this real quick. Okay, so ethyl and beverage, and it says grain, and then it says beverage. Somewhere. That's what IQ doing. Okay, so you're doing alcohol, grain. So let's say it was an accidental poisoning. Most of it would be. And so it's grain and T51.0X1. And again, the beverage is the same code, T51.0. So you're going to take that code, write it down, Joyce. So like grain, we're under alcohol, right? ALCOHOL, grain. And then we're going to accidental. And that is going to be T51.0X1. All right. So now we're going to take that code because we're not going to, believe everything we see in the drugs or chemicals, right? So we're going to go back here to the T codes. T51 is going to be around page 1048, T51. And it says right here, toxic effect. T51 is toxic effect of alcohol. The appropriate seventh character to be added to each code from this category is A, initial encounter, D, subsequent encounter, or S for sequela. So T51O, toxic effect of ethanol, ethyl alcohol, and then X, we want 51X, is toxic effect of methanol, and we want accidental, so that's going to take us to the T51.1. See, I don't want 1X, I want OX1. So I'm right there, T51.0X1, toxic effects of ethanol, accidental, unintentional. Do you see that? Okay. So as long as you're not seeing anything else you might need there, it's okay to go ahead and code this with this one code. Okay? See, nurses in the ER are often in a very good position to overhear patient comments. Something I want to talk to you about. It's happened to me a couple of times. I wasn't there as a person, a clinical person. I was there as a mom. One of my kids I had to take in for some reason. Heard somebody in the next cubicle. Well, I don't know how he got a hold of that stuff. That's what I heard. I heard the mom say that. I don't know how he got a hold of that stuff. But when the doctor was in there with them, they were saying they had no idea what happened. That's what they told the doctor. Well, we have no idea what's wrong with this kid. He's about 3-4-year-old boy. And they were, doing some emesis with him, trying to get it up. So I pulled my nurse over that was dealing with my son, and I go, there's an interesting conversation over there in that cubicle. She looked at me and she goes, really? I go, yeah. She goes, what was it? Because she was not the nurse on that case. She said, what happened? I said, well, I heard the mother over say, well, I don't know how he got a hold of that stuff. Which kind of was different than what they had told the physician, which they had no idea what happened. So if I'm in a position to hear stuff, I know you're in a position to hear stuff. Of course, most people don't have any idea what anybody's talking about, so that helps, I guess. See, here's the thing. We have poisoning undetermined column. That is not benign. That is not like unspecified. This is very important that you catch this and be very aware of it, because that means that we don't know the cause, and it could be intentional, either through self-harm or through assault. Okay? So anytime I see these, I'm like, wait a minute, what happened with this case? Depends on what I'm doing. I just find it interesting. I'm kind of nosy that way. So over here on page 172 of your 321 code, it is applications of seventh characters in chapter 19. So this is a sign for you to really read carefully. character requirements for each applicable code, which is a little different than, the other sections that we've seen. Okay, so that is actually related to the encounter. So you have quite a bit of information here. So page 173, 174, 175, 176. And this takes you into maltreatment. Let's see. So G, complications of care. I shouldn't say maltreatment. Wasn't correct. General guidelines for complications of care and documentation of complications of care, for information on documentation, and then pain due to medical devices. So that's number 2. That takes you over to G9. So what's interesting about this section is you may see, the effects, but you're not quite sure what caused them or how, or shall we say who caused them. So this section is, you always kind of have to have your antenna up for the table of drugs and chemicals to really be aware of this, because what we're trying to do is really track adult and child abuse, neglect, and other maltreatment. So that was F, under toxic effects. Sequence of the first appropriate code from category T74. So again, we're tracking things differently now because we have better codes. So you have on page 177 and 178, you have exercise 4.21, injury, poisoning, and certain other consequences. You're going to underline the main term in each diagnostic statement and assign the appropriate ICD-10 code. Do not enter codes for external cause of disease and injuries. So I'm not quite sure why we're doing it that way. So follow the instructions as you see them there, because that's what's going to be in my answer key. Chapter 20. Chapter 20. External causes of morbidity, V00 through Y99. These are interesting. Patient injured in a transport accident, motorcycle rider, pedal cycle rider, occupant of a three-wheeled motor vehicle, car occupant injured in a transport accident. Goes on and on and on. There's a complete list here. So let's go to section 20. I'm looking up your in your coding manual, your ICD-10, and it starts on white paper, white space on 1078. Never know when you're going to need it. Hint, hint, hint. Okay, and then your chapter 20, then external cause of morbidity, starts on 1079. Lots of interesting, well, not lots, but there's really good coding guidelines here. Place of occurrence guideline. Place of occurrence is really important to track, especially these days as we're all getting all these interesting terrorist things happening. We have to code those. Somebody has to code it. Place of occurrence guideline codes from category Y92, place of occurrence, external cause, are secondary codes for use after other external causes. So when 9/11 happened, we did not have codes for that. For an airplane flying into a building on purpose. So that's where we got the terrorism codes that you will see here. Where are the terrorism codes? Should be in the index. I've completely removed them. Let's see. So let's see. Exposure to forces of nature, event of undetermined, exposure to, I'm sure it still says terrorism. Exposure to inanimate. Legal intervention. Operations of war, military, and terrorism. There we go, legal. So they kind of moved them around. They were separate under terrorism in ICD-9 when they came out. So unfortunately now we do have codes for this. Accidents, transportation accidents, and pedestrian injured. It's very, very, we've got V03.92. Look at that on page 1085. Pedestrian on skateboard injured in collision with car, pickup truck, or van, unspecified whether traffic or non-traffic. Now, they could run right into a parked car. Not great, but they can. So when you're looking through this and you're doing some of your homework assignments, you're going to see a lot of, we really got some really good green code in here, green text, and that gives you very, very specific, like, look over on page 1888, V14.0, pedal cycle driver injured in collision with heavy transport vehicle or bus in a non-traffic accident. It's pretty specific. So let's click over in have exposure to, you would look under the word exposure in the alphabetic index to find this back here. Exposure to electric current or radiation, exposure to smoke, fire, flame, exposure to forces of nature, X30 through X39. We have X35, volcanic eruption. You have intentional self-harm, X71 through X83. You have assault, starting on page 1128. Includes homicide and injuries inflicted by another person with intent to injure or kill by any means.